So my dear friends, I will try to defend the metal back, and I know it's a polemic problem, and I don't think that it's possible to solve it today, but I will explain you why. Since 2003, for more than 19 years, I am still using the metal back in the total anatomic shoulder arthroplasty. You can see I have a conflict of interest as I am a designer of a arrow system. Please, it doesn't work. Could you, the next slide, I think it doesn't work. Okay, it works, thank you. So the question is it a comeback to a future or maybe to a failure? I think it doesn't work. Next slide, please. It's not new because the first metal back has been imagined by Charles Neer, and we had a very bad, thank you, we had very bad experience with all this metal back component, and especially the one of Equalis from Pascal, who published this paper many times to show that it's a very bad idea. I'm not sure it doesn't work. Next slide, we are going to do maybe. So is it the tools of the devil? You can see all these publications that show that it's a very bad idea. And maybe the glenoid cemented one could be still the gold standard. Next one, please. And the last publication who killed the metal back was the one of Pascal, again in 2015. Next, please. And out of 165 total shoulder arthroplasty Equalis, with a follow-up of 2 to 16 years, and this is a long follow-up, the longest in the literature. You can see all these complications, and 37% of revision, only 46% of survival rate, 19% of losing, disassembling, rotor cuff tear, instability, and so on. Of course, we can understand that Pascal stopped. The next one, please. But Pascal stopped, but do you think Pascal and other authors have a good answer? Do you think the cemented one could be a good option? You know that revision of the cemented one is always difficult with devastating bone loss on the glenoid side. Next one, please. Here is a few publications regarding very significant, important study in case of number of patients, and you can see we have a lot of complication rates only regarding the cemented glenoid point. So the cemented one is probably not the best option too. The next one, please. We know with Lazarus when we can find till 80% of radiolucent line. Of course, when you read Neer, Rodowski, Brems, and Caulfield, apparently this radiolucent line around the glenoid are not symptomatic. Nevertheless, we know with two last paper, and especially Bozzali and Madsen, then in case the main cause of revision is come from the glenoid side, exactly as said Claudio. Next one, please. If you think how can metal back can help you, we know we have good results with the reverse shoulder plasty, and we can make a graft, we can make bioassay. You see the very nice communication of Pascal. We can make conversion, we can make a bone reconstruction, you can control the glenoid dysplasia, the glenoid cyst. You can revise a semantic one with a metal back, and of course the bioassay works. So the metal back can work. Why does it work with reverse but not with anatomic one? Next one, please. So as I told you, since 2003 I have been implanted only metal back in my arthroplasty. No, the next one, please. Yes, thank you. And the question is, it is the metal back a tool of the devil or between madness and genius? So next one, I will just show my experience. And we have few publications. And next one, you can see the first question. I just propose you to answer to 6 questions, even if there are more. The first question is, we used to say that the metal back is thicker than the cemented one. If you make this comparison, in fact, it's not really evident. Next one. Yes, in our prosthesis, we have 2.5 millimeters thicker than the cemented one. But I'm not sure much my surgery is so precise, especially when you have to rim plus or minus 1 millimeter. I think it's difficult. So we cannot consider that the metal back is really thicker than the cemented one. Next one, please. So what about the rotator cuff? In our series, we have 2% of rotator cuff tear with a metal back and 2.6 with a cemented glenoid component, because some surgeons in our team prefer the cemented component. So we have no more glenoid rotator cuff tear with that. And we can see over study, as you can see with cemented glenoid, you can see frequent subscap tear, so it's not the privilege of the metal back component. Next one, please. Next one. What about the wear? So I think we touch here the heart of the problem. Yes, thank you, my friend. We have in our series 4.9% of glenoid wear, poly wear, but this poly wear, you can see after 10 years of evolution for this patient, yes, we have a wear, you can follow it, but it's not always symptomatic. I don't say it's not a problem. I consider it could be a problem. Yes, it works, great. But sometimes this poly wear can create some osteolysis, and especially around the humerus, and you have to make a revision. So it could be a problem. But as you can see, you will see, especially in glenoid B2 or C. So regarding the disassembling possibility, this existed before the 2008, but after we have made a modification of the technique of impaction, and we have no problem now with the disassembling. What about the dislocation? The average of the dislocation in our series is 5% with a metal back. And you can see we have compared the cemented one on the top 3% of dislocation versus metal back, 6% of dislocation. So you can say yet it's more, there's a problem, but we've made metal back in the B2 and C glenoids 5 times more, and because of that, we cannot say that we have more dislocation in total back. So there is a risk of dislocation if you use a metal back in the B2 and C glenoid, we know that, and maybe the idea of anatomic shoulder arthroplasty is a bad idea in case of B2 or C, but the metal back is not the cause of this problem. So what about the metal back loosening? In this publication, out of 143 cases, we have 0 case of loosening of our metal back. But look at, in this publication, the rate of loosening of cemented glenoid, which is clear. So to sum up, if we compare our experience with the one of Pascal Boileau, we cannot confirm his result. We have less complication, and we cannot condemn or kill a metal back. Pascal can talk about his metal back, and he's right to stop because he has a lot of complication. But since for 19 years now, we are still using the same metal back. The metal back can have some advantages, not only drawbacks. Of course, it is a platform system, and this is the point of our next communication. And I would like to show you how you can make a glenoid reconstruction. This is a cadaver lab, and there is no bone inside, there is no anterior bone, and a metal back, of course, can help you to make a very significant reconstruction and to push the limit of of your surgery, and just with this long keel, which you can see will cross the native bone, this creates a counterforce, and it is really mini-invasive because you drill 6 millimeters and not 8, and this is one of these great advantages of a metal back, and it works also for the anatomic shoulder prosthesis. So finally, we consider that the metal back is a war or a French debate between Pascal and our team, and the problem is not the metal back, but the problem is the poly, and the debate has changed, and for us the metal back new generation, that means 2003, can help us a lot for many things. So of course we are working on a new design and an evolution of the different components of the prosthesis, but we are still using the metal back for the total shoulder anatomic arthroplasty. Thank you very much.